Hello, dear participants. Welcome to my presentation. We are passing very difficult times now all over the world, including Bangladesh, for COVID-19 pandemic situation. I am Dr. Kanral Shaha, working as an associate professor in the Department of Otolaryngology, Head and Neck Surgery, Bangabandhu Sheikh Mujib Medical University, Dhaka, Bangladesh. Bangladesh is a South Asian country. It is the 8th most populous country in the world. Bangladesh is one of the emerging and growth leading economies of the world. We have the longest natural sandy beach in the world, in Cox's Bazar. We are proud of our national heritage, the Shohid Minar, built in the memory of the martyrs sacrificed their lives for their mother language. In 21st February 1952. In the memory of the day, the 21st February is celebrated as an International Mother Language Day all over the world. We are also proud of the Sundarbans, the largest mango forest in the world, which is a UNESCO World Heritage. This is my university where I work. Now I would like to share our experience of external auditory canal cholesteatoma. External auditory canal cholesteatoma is a lesion lined with stratified squamous epithelium containing proliferative keratin debris with bony erosion. It is classified as primary and secondary external auditory canal cholesteatoma. It is a very rare clinical entity with an estimated incidence between 0.19 and 0.3 cases per year for 100,000 population. It is 60 times less common than the medullary cholesteatoma, and for that it is very often a misdiagnosed condition. The incidence of secondary external auditory canal cholesteatoma is higher than the primary external auditory canal cholesteatoma. Because of overlapping clinical features, the keratosis occurrence and the external auditory canal cholesteatoma have been previously described as an similar pathological condition and interchangeably used in the literature. But in 1980, Paraganglioma et al. First demonstrated the definite clinical and pathological findings of external auditory canal cholesteatoma and described the differentiation and management of primary external auditory canal cholesteatoma and keratosis occurrence. Though the exact etiological factors of primary external auditory canal cholesteatoma are still unknown, there are some potential risk factors such as cotton-tipped applicator abuse, nicotine abuse, old age, diabetes mellitus, and hemodialysis. The etiological factors in case of secondary external auditory canal cholesteatoma are usually identifiable, such as the congenital or acquired external auditory canal atresia, post-traumatic, post-operative. The cardinal symptoms of primary external auditory canal cholesteatoma are unilateral otorrhea and otalgia associated with hearing loss occasionally. It may be asymptomatic in early stage. The predominant symptom of secondary external auditory canal cholesteatoma is the hearing loss associated with otalgia and otorrhea. The diagnostic hallmark sign of primary external auditory canal cholesteatoma is direct automicroscopic observation of bony defect in the inferior or posterior wall, usually with the intact tympanic membrane. In case of secondary external auditory canal cholesteatoma, there may be random involvement of the external auditory canal wall. The high resolution CT scan of the temporal bone, especially in the bone window, is the investigation of choice for demonstration of bony defect in the external auditory canal, as well as to localize the cholesteatoma. It also helps for staging and planning the treatment. Pure tone audiometry is to be done in all cases, like that of other otological conditions. The definite treatment of external auditory canal cholesteatoma depends on the clinical staging, from conservative to burial surgical interventions. Usually, Naim et al. System is followed for staging of the external auditory canal cholesteatoma for planning treatment. There are 4 progressive histopathological stages, including stage 1, focal epithelial hyperplasia, stage 2, followed by accumulation of inflammatory cells in the adjacent stroma leading to the periostitis, stage 3, accumulation of keratin debris causing erosion of the bony canal, and stage 4, erosion of the adjacent structures. In the current series, the medical records of 10 cases of external auditory canal cholesteatoma operated in our center were reviewed from January 2012 to January 2020. Clinical staging is done according to Naim et al. Staging system. The patients with external auditory canal cholesteatoma completed at least 12 months follow-up were included in the study, and the cases are classified according to the Dubeck and Hostler classification system. The objective of our study is to characterize the clinical presentation, to discuss the surgical management, and to evaluate the outcome and complications. High resolution CT scan of temporal bone were done in all cases preoperatively. Preoperative and postoperative audiometry were recorded in all patients. Preoperative, peroperative, postoperative findings were documented in photo image and video recording systems and preserved in a storage device. Regarding the demographic profile of the external auditory canal cholesteatoma in the current series, the mean age was 20 years with the age range of 5 to 50 years, with male-female ratio 7:3. All are from Asian. Among 10 cases, primary and secondary external auditory canal cholesteatoma were equal in number, 5 in each group. All cases had unilateral presentation, 7 in the left ear and 3 in the right ear. Regarding the clinical presentation, all primary cases presented with otorrhea. 3 cases had the otalgia and 1 case presented with the hearing loss. On the other hand, the hearing loss and the otalgia was the predominant symptoms in case of secondary external auditory canal cholesteatoma. The most common site of lesion in case of primary external auditory canal cholesteatoma is the posterior wall, 4 out of 5 cases, and 1 case involved in the inferior wall. And there are multiple wall involvement noticed in the secondary external auditory canal cholesteatoma. Stage 3, stage 2, stage 3, and stage 4 cases were found in our series. 6 cases, including 4 from primary external auditory canal and 2 from secondary external auditory canal cholesteatoma, were categorized as stage 4. 3 cases were categorized as stage 2 in case of secondary external auditory canal cholesteatoma, and only 1 case is categorized as stage 3 in case of primary external auditory canal cholesteatoma with tympanomastoid paraganglioma. Regarding the treatment modalities, canal wall down mastoidectomy in the form of modified bonding mastoidectomy with preservation of the ossicles were done in all stage 4 cases. Among the stage 2 cases, 2 were managed with canaloplasty and 1 was managed with removal of foreign body and granulation tissue. And only 1 case of stage 3 primary external auditory canal cholesteatoma associated with the tympanomastoid paraganglioma was managed with canal wall down mastoidectomy with type 3 tympanoplasty. Here there are brief review of few cases of external auditory canal cholesteatoma. This is a case of 9-year-old boy presents with primary external auditory canal cholesteatoma in the left ear. You can appreciate intact tympanic membrane with eroded posterior metal wall. CT scan shows the eroded posterior metal wall. Post-op endoscopic picture shows intact tympanic membrane with healed mastoid cavity, and post-op putative audiometry revealed normal hearing. This is a very rare presentation of tympanomastoid paraganglioma with the primary external auditory canal cholesteatoma in a 16-year-old girl. You can appreciate the coronal CT scan here with the hyperdense lesion representing the vascular paraganglionic tissue and isodense lesion in the eroded floor of the external auditory canal represents the cholesteatoma. Actually, it was an incidental finding during removal of the tympanomastoid paraganglioma. We noticed a isolated bony erosion in the floor of the external auditory canal with keratinous debris. And this is another case of secondary external auditory canal cholesteatoma, the left ear, in a 50-year-old male presented 5 years after tympanoplasty. Preoperative autoendoscopy shows the keratinous debris with intact tympanic membrane, and CT scan reveals the intact scutum with an isodense shadow. And perioperative findings confirm the eroded superior wall of the external auditory canal cholesteatoma with keratinous debris and intact tympanic membrane. This is a case, another case of secondary external auditory canal cholesteatoma in congenital stenosis. You can appreciate the stenosis at the bony cartilaginous junction, and peripherally you notice the keratinous debris after exposure. This is another case of secondary external auditory canal cholesteatoma in a 10-year-old boy presented with the granulation tissue and otalgia. At the removal of the granulation tissue, we noticed a wooden foreign body in the external auditory canal. After removal, we found the cholesteatoma. Actually, preoperative imaging, there was a isodense lesion in the external auditory canal with a hyperdense lesion, which was missed by the radiologist as an unusual presentation. As an outcome, the audiological outcome shows the primary external auditory canal cholesteatoma. Preoperative mean airborne gap was 19.3 and postoperative mean airborne gap was 13.1. And in case of secondary external auditory canal cholesteatoma, preoperative mean ABGO was 42 and postoperative mean ABGO was 21. Regarding the complication, we noticed a case of facial palsy, House Beckman grade 2 facial palsy in the 7th postoperative day, who is completely recovered within next 2 weeks with conservative management. And we also recorded a re-stenosis in one case of congenital stenosis after 6 months. So in a conclusion, we can say old age may not be a predisposing factor in case of primary external auditory canal cholesteatoma. Instead of inferior wall, posterior wall involvement in primary external auditory canal cholesteatoma explains the extension of mastoid in stage 4 diseases. Early stage of primary external auditory canal cholesteatoma, stage 1 and stage 2, can be managed with conservative approach. Advanced stages of primary, including the stage 3 and stage 4, and most cases of secondary external auditory canal cholesteatoma require surgical intervention. So that due to rarity of a disease, a high index of clinical suspicion can help differentiate the external auditory canal cholesteatoma from keratosis operans and other external auditory canal lesions. Thank you for your patience hearing. We believe the current pandemic situation will be over very soon, and we hope that we'll meet our next meeting physically.